Our speaker is Dr. Issac Kajja, who's a senior lecturer in the Department of Orthopedics at the School of Medicine at MAKERERE University College of Health Sciences in Kampala, Uganda. He will be speaking on transfusion in trauma.
Thank you so much for the kind introduction. So I will briefly talk about the epidemiology of trauma, the approaches to the severely injured patients, the acute coagulopathy of trauma and shock, massive transfusion, challenges of blood resource procurement, trauma for trauma in sub-Saharan Africa, then challenges of in-hospital blood management, then the way forward. The burden of trauma surpasses the patient himself who is traumatized. It goes beyond the patient, it goes to the family, the burden goes to the society, it goes to all sorts of people attached to this person, including the nation. So, as far as the person who is traumatized is concerned, you can see this young man. He has been traumatized, but is attempting to cope with the requirements of life. Trauma is a neglected epidemic in the developing countries, causing more than 5 million deaths each year, roughly equal to the number of deaths from HIV/AIDS, malaria, and tuberculosis combined. And these are the programs that are very well funded the world over. The burdens of trauma equate the burdens of those other diseases combined. Actually, by 2020, up to 20% of the global disease burden will be secondary to trauma. It is only about 5 to 6 years from today, implying that as we move towards 2020, the burdens of trauma are actually approaching 20% of the entire global disease burden, yet the funding is still meager as regards trauma management, trauma care. More than 90% of the trauma deaths occur in low and middle income countries, and sub-Saharan Africa houses all or most of the low income countries globally. Preventive efforts and healthcare systems are least prepared to meet this burden in these settings. For example, our trauma centers are poorly developed where they exist or they are non-existent. We need rehabilitation centers to address our trauma, which rehabilitation centers are actually non-existent in many of our settings, and where they do exist, they are poorly developed. Trauma clearly adds to the vicious cycle of the economic and social burden upon individuals, communities, and societies. How do we get this trauma? There are vectors of trauma or things that lead to trauma in our settings, like motor vehicle accidents, firearms, burns. Our fellow human beings can actually traumatize us by assaulting us. And one thing for sure, the resources allocated to the trauma management are still meager. For example, the per capita expenditure on road safety in Uganda is only US dollars 0.09. And in Pakistan, which is another low-income country, it is up to 0.07. These are very prominent pictures. These are scenes that are common for some of our colleagues who come from Nairobi, Kenya, and Ghana. Then where? I've not been to Accra, but I have been to Nairobi, Mombasa, and Kisumu, and Eldoret. These are not unique to Uganda. This kind of arrangement is found in many parts of Africa and Southeast Asia and the Caribbeans. This kind of picture is not unique to Uganda. In Mombasa, you have tukutuku, which does a similar, we call it boda boda here. For you, you call it tukutuku. In Ghana, you call it okada. Aha. They all do a similar kind of service to our communities, but they are being driven on narrow, poorly maintained roads by lawless and reckless drivers. They are most times have smoked or have injected themselves with the drugs. In fact, as you are being carried on some of these motorcycles or boda boda, okada, you actually smell, pick a smell of these drugs. And it is not rare for us to use these roads with animals. At one point in time, I was driving my old car, and all of a sudden, a boy carrying a sugar cane transversely entered into the road and actually blocked both lanes for about an hour because he was hit by a motorcycle and got a fracture just in front of me. So all these are the problems that lead into the severe traumas that we have. We have this overload as a standalone challenge where you can get up to 5 passengers on a motorcycle. Now, the approaches to the severely injured. We need to come to standby infrastructure. We need to establish sound trauma centers with standby human resource, very well trained, very well facilitated, with clear policies to address, policies, standards, and procedures to address this trauma. These may include surgeons, orthopedic surgeons, neurosurgeons, anesthesiologists, critical care nurses, and we need these facilities to be very well prepared. For example, we need good operating rooms, functional, good blood supplies, good diagnostic facilities, and ICUs. And within these infrastructures, we are supposed to base our practices on very well grounded and researched and rehearsed good clinical practices if we are to handle this burden. For example, we can base our management on the advanced trauma life support courses, which need to be taught and assessed to all our residents, regardless of whether you are doing medicine or pediatrics or hematology. You need to go through these courses, because in these settings of Africa, you can find that a pediatrician handles all the issues in a regional referral hospital, including surgery and obstetrics. Is it true? Yeah, the moment you have a specialist anywhere, in any of our regional referral hospitals, he will be called upon to handle everything. And he will be overseeing 1 or 2 medical officers. So, as far as our training models are concerned, we need to include this, as I will allude to it later, in our way forward strategies. So, on arrival in the emergency unit, I have come up with a few points that we could pick and it could help us address this trauma in an emergency situation. The ATLS guidelines stipulate that 2 large bore needles should be inserted, and we should run crystalloids of up to 2 liters. We can only give a blood transfusion if the patient remains hypotensive and if the patient gains normal blood pressure but subsequently becomes hypotensive, or if the patient continues bleeding at a rate of about 100 mils per minute. We should remember to start plasma and platelets, but this should be based on laboratory results. For example, the international normalized ratio of above 1.5. INR, if we may go through it, is the PT of the patient over the standardized PT for that laboratory raised to a power of ISI, the International Sensitivity Index of that reagent that is being used. So, if we are able to do that, then we can start our plasma and platelet transfusion. But that one is purely to look at it. That one only addresses the extrinsic and the common pathway. But we also need to come to assessing the intrinsic and the common pathway by doing the activated partial thromboplastin time. I will get into the details later. So, but we also need to do platelet count before we can jump into giving platelets in a trauma patient. Okay? And if we have uncontrolled bleeding, we can transfuse fresh frozen plasma, 1 unit of fresh frozen plasma to every 3 units of red blood cells, because of what we are yet to see. In case you are unable to control this bleeding, then we have to switch to the damage control. From the ATLS guidelines, we have to switch to damage control, and this one includes it includes issues, having considered issues of iatrogenic resuscitation injury, like hemodilution. You put in your 2 wide-bore needles, you start pouring their normal saline and Linger's lactate and blood, but at the same time, you are causing hemodilutional coagulopathy with the increasing blood loss and the fluid and RBCUs. You end up getting coagulopathy. So, your concern with this primary surgical repair and closure of whatever is open and is bleeding would be to address the hypothermia, like in prolonged abdominal surgery, or acidosis following prolonged resuscitation. So what do? We control the hypothermia, that is, we rapidly arrest the blood loss. We avoid soiling the peritoneal cavity, so you pack it and you come out quickly. Then for us, orthopedic surgeons, we need to do early stabilization of fractures. Then we have to remember to introduce fresh frozen plasma and platelets early. You have seen how fractures take long to be fixed in our settings. That is a big issue, which we are now addressing. We need to come up with a policy. We are trying to come up with a policy of fixing these fractures as they come to the hospital. But remember yesterday we talked about failed systems all over the place. If the systems of delivering a unit of blood to the bedside is not functional, then you will not be able to fix this fracture. Systems need to be fixed. All systems need to be fixed in order for you to come up with the operational policies. Now, I would like to spend some 1 or 2 minutes about acute coagulopathy of trauma and shock. Trauma per se causes coagulopathy because of dilutional dilution, the dilution that follows resuscitation, the consumption of the clotting factors, the hypothermia that results from massive blood loss, and acidosis that follows hemorrhage. And the fibrinolysis combine to limit the fibrinolysis. All those factors combine to limit hemostasis. And what is worrying, when you would be worried if you got results from the laboratory where you have a prothrombin time which is above 18 seconds and the APTT which is above 60 seconds, or thrombin time which is above 15 seconds. How does trauma cause all this? I wouldn't want to bother you so much about the clotting cascade. This is one topic which is very, very unfriendly to many doctors. Now, I'm not going to go into it because we have other things to do. But at least what trauma does, it stops the formation of the clot, the stabilization of the clot. Trauma itself leads to lysis of the clot that would normally form. Okay? Can I go through it? You have allowed me. Now, what happens within the blood vessel? There is protein C. Research has shown that this protein C, the levels following trauma, the levels of protein C actually increase. And the increase in levels of activated protein C, this one, protein C decreases as activated protein C increases. And this leads to inactivation of factor 5, which is very important in the stabilization, propagation and stabilization of the clot. Remember, the clot is formed in 4 stages. I'm again drawing into, you're tempting me to draw into that thing, which is very unfriendly. But we need to know it. There is initiation of clot formation. There is propagation of clot formation. Then there is a stabilization and of the clot. Then lysis of the clot. Now, factor 5 is very important in 2 of those stages. That is actually amplification before lysis. It is important in propagation and amplification of the clot. Thank you, Professor Heather. You gave us a very nice book. I wish all of you took this book. There is a small book. Instead of the T-shirt, you would have picked that book. Did you pick, particularly the doctors? The doctors, you should take that small book from Professor Heather. It is called the blood coagulopathy. Blood easy coagulopathy. Okay? It will make you learn this process very well and do your orders for these plasma and platelets when you are very well informed. Aha, you have it? Yes. All of you should pick that book. Take back the T-shirt and pick that book. Okay, we continue. But what trauma is going to do is to increase the levels of activated protein C, and this activated protein C is going to inhibit the inhibitor of plasminogen. This is a plasminogen activation inhibitor. Okay, so that now the levels of because the trauma causes the tissue to release a tissue plasminogen activator. Okay, so eventually the clot will be lysed, and once the clot is lysed, the bleeding is going to be augmented. It is going to increase. So trauma itself causes bleeding to be propagated. So what did these boys do of the crash? Clinical randomization of an antifibrinolytic in significant hemorrhage. What these people did, they had the tranexamic acid. They looked at 20,211 injured patients. They randomized them and found out that once they gave this antifibrinolytic agent, they significantly reduced death in hospital stay, during hospital stay within 4 weeks. They randomized their patients. Some were getting the drug, others were getting the placebo. And up to 16% of these guys, 16% of the patients on placebo died, and 14.5% died. And this was statistically significant. So this agent is useful because it acts here. You see, that is why I had to take you back a bit, because I knew that I was coming to this slide. Then that was the primary outcome. Then when they did the secondary outcome, still they found that there was a difference between the people who took the drug and the people who did not take the drug. And the difference was statistically significant. Okay? So this point here was tested. They did a clinical randomized trial of the drug. Okay? Good. Now, a few points about massive transfusion. Usually, this is defined as transfusing 10 units of red blood cells in less than 24 hours. It can happen. Even in not those of obstetrics, PPH and APH can lead you into transfusing. Have you had an experience, the obstetricians around? Have you had an experience of transfusing at least up to 50% of the total volume within 3 hours, if you are to save this mother? Okay? And the complications of those massive transfusions can actually be circulatory overload, or you can induce hypothermia, the core temperature goes down, or you can have citrate toxicity. Now, how do we prevent dilutional coagulopathy? We need to request for fresh frozen plasma and platelets are enough if you anticipate transfusion of, say, more than 5 units of blood. Okay? For example, if you have a ruptured liver, you anticipate that when you go in to start repairing this liver, you definitely will need more than that amount of blood. If you have a ruptured aneurysm and you are able to reach theater with this patient, you need to anticipate that you are going to use more than 5 units of blood. So you also order for FFPs and platelets. If more than 50% of the blood volume is, you anticipate it to be replaced during resuscitation, then you need to transfuse up to 1 unit of FFP for every 1 to 3 units of blood. The ratios of these transfusions, of the transfusions of these units, of the various components, is still controversial. Some writers, some researchers will tell you that you can transfuse 1 to 1 to 1. That is platelets, FFPs, RBCs. Others will say transfuse 1 to 2, while others will say transfuse 1 to 3. So the controversy calls for research. And there is a study that is complete, and these guys did a prospective multi-center randomized trial that compared a 1-to-1 versus a 1-to-2 ratio of FFPs to RBCs in trauma. The work is finished, but it is not yet published. It is being analyzed. Okay? This is a $50 million piece, which has been sponsored by the U.S. Army. And we are happy when it comes out, we shall make use of it. But remember, these ratios are also population-based. They vary from population to population. They may have done this piece in countries which are not sub-Saharan Africa. At one point in time, they may have, some of these works may need to be tested in our environment before we can adopt it, okay? But at least we shall have a working guideline, okay? Now, what are the challenges? What do we have as far as blood use or blood management is concerned in hospitals? Remember, we have limited resource allocation to transfusion quality systems, and we have unacceptable blood management systems within the hospitals. Fortunately, we have alluded to this in most of our lectures yesterday. The human resource is still lacking. We have insufficient numbers of transfusion specialists, and the competences are not yet, our competences are not yet established. There is lack of training and continuous professional development. For those who know something, they tend to stop on what they knew when they were in the medical school or when they were doing a postgraduate. There are no programs for CPDs, and the curricula do not formally address in-hospital transfusion medicine details. Fortunately, the UBTS is attempting to liaise with Mbarara University to come up with a formal course about which will house us in transfusion medicine issues. And I don't know when it will come to pass, but that is a good initiative. Then we have organizational management issues. Now this is very interesting, really. So the in-hospital transfusion medicine SOPs are still underdeveloped. The attitudes of clinicians towards accountability for the supplied blood are still questionable. The clinicians will not bother to account either to UBTS or to the patient or to the hospital administration as to what has really happened to the unit of blood that was picked from the blood bank. The clinicians are reluctant. That one doesn't need to be taught, but we just need to change attitude towards and appreciate that this is a very useful organ that we are handling. First and foremost, we didn't donate it. Our duty is only to give it to the patient. But we have not yet appreciated that we need to account for this product, which is very unfortunate. The hospital transfusion committees are still lacking. Now, when you see such a situation, that picture brings out so many things, really. The cold chain within the hospital, the oversight within the hospital, the training per se. If somebody has really been trained well, even if there is no tray or towel to cover the unit of blood as you bring it from the blood bank to the bedside, if somebody has been trained well, at least he would put this unit of blood in a box and cover it and run quickly to the ward. He would refuse actually to pick it from the blood bank if there is no container to bring it. But this person has not been properly managed. There is no organizational structure. He has not been trained. There are no standards to cater for this. No one is monitoring him. So the entire quality, the backbone of quality systems within the hospital is represented by this picture, this photograph. So we need to wake up and look at the quality systems within the hospital setting. Communication. Communication of blood needs is inadequate. The clinicians lack knowledge of the available products that are supplied by their banks. We don't know what is in the bank. Meanwhile, the blood bank staffs do not appreciate the problems that we have in the hospital setting. Okay? I did this work some 4 years ago, which found out that fact, and it is published. You can look it up. So a nationwide survey of the epidemiology of blood needs and use should be conducted in addition to exploring achievable communication strategies at the clinical interface. That is the suggestion that I would give as far as communicating the need and communicating the supply is concerned. Way forward, funding. Look at this graph. This graph shows how the U.S. caters for its people as regards resource allocation. We need to encourage our governments to stick to resolutions to which they are signatory. Yesterday I was mentioning the World Health Assembly resolutions and the Abuja resolutions that stipulate that our governments should allocate up to 15% of our national budgets to health. At least if they could give us 10%. Doris, how much do we get? Because you are nearest to the minister in this room. How much do they allocate to the Minister of Health? Aha. 7% or 9. Okay, then it is 8. 7 plus 9 divided by 2 is 8. Now, sincerely, if we are getting 8% of this budget and we are carrying blood in our clinical court pockets, if they only increased up to 14, probably we would be able to buy boxes, cool boxes for all our hospitals. It is terrible, gentlemen and ladies. Now, these people, look at this. This is 100. This gap here, this is 0. This is Africa. This is the European Union. They go up to maybe 2,000 per person, per capita expenditure on health care as of 2005. Now, for us in Africa, we are down here, below $100. Now, these guys are talking of $2,000. These ones are going up to $7,000 in 2009. Agreed, they are developed. Agreed, they have a long history of health care advancements. But sincerely, $100. This is tricky. Maybe let me leave that. In case I don't politicize it. Okay, partnering. Now, these other programs, the HIV, AIDS, malaria, MCH, tuberculosis, these programs are better funded than our transfusion services. I wish we had invited some people who also work for these programs or who are involved in these programs. These programs actually have patients who use our blood. And yet, they are better funded. So, Doris, what we need to do is to partner with these programs. Tell them that we have shortages in funding, in procurement, in processing and distribution of blood, so that we can use some of their good offices and some of their money to also facilitate in hospital transfusion-related activities like training and provision of supplies. But all this comes with the proper oversight. You cannot partner with somebody without a good organizational structure. We are not going to send you now to go and bump into the program directors. So we need to lay foundation for this partnership. Okay? Education. We need to lobby our universities and paramedical training institutions to give a deserving allocation of time to training in transfusion medicine. In the short term, we could begin with the 4-week rotations in hematology units and blood banks in the short term. You know how difficult universities can be to change goalposts as far as time allocation is concerned. People who work for universities are very rigid. The universities are not the ones which are rigid, but the people working in those universities are very rigid. So we need to lobby carefully and intelligently. In the midterm, we could do transfusion training in the clinical area that use blood, like in surgery, in oncology, in pediatrics, in medicine, and in the long run, we shall end up with the full curricular adjustments and put in place fellowships in transfusion medicine. Very well grounded and very well funded. Participation. We need to improve communication between the clinical setting and the transfusion services. And we need our clinicians to become more accountable. And in that vein, exchange of ideas on ward rounds with the specialists. We can invite the blood bankers to come around as we do our ward rounds. But we can also send clinicians to rotate in blood banks, like the exercise we are going to have tomorrow. I would urge all clinicians in the room to go to the blood bank so that we see what happens there. But additionally, I would urge all blood bankers, I don't know how you'll do it, but I pray that you are able to be in two places at the same time, because we don't have time for two activities. I mean, I don't know how Professor Zik has prepared this, but the point I want to emphasize is building respect on each end of the transfusion chain. And that would improve blood practice for the trauma patient. So let us be on both sides. Let us understand our colleagues in the procurement and the processing section, but let them also come and understand the situations in the hospital. Probably eventually we shall have a national voice through a national transfusion committee that is going to address these issues, because we can't leave it alone to the UBTS. We need to come up to a national voice. Our brothers from Kenya, the visitors came only from Kenya and Ghana. Do we have visitors from other countries? I don't want to leave this without mentioning other countries when they are here. Okay. Research. This is for the collaboration. We need to invest in trauma and transfusion research with a clear agenda to generate sub-Saharan evidence to base our practices. Okay, I've already talked about that, and we should find answers to basic questions like who, why, and when, and how often, and by whom is this transfusion made? Which type of trauma do we really have? And what does this type of trauma, why does it occur in that area, therefore requiring how much blood products? Those are very many questions. They are quite basic, but they can influence policy and funding to our transfusion sector and trauma management. Therefore, we need to do a detailed epidemiological mapping of blood use in trauma in sub-Saharan Africa and urgently. With those few remarks, I thank you so much for being a wonderful audience. Thank you.